Fine. You've been allotted 8 minutes for each presentation, and if the panel of judges will want to ask a question or two at the end of your presentation, just don't get tense or anything. Please answer your question as well as you possibly can. So wish you all the best. As soon as I have the list of presentations and the assessment chart that Dr. Sandeep Gupta is bringing in, we will be starting. Dr. Major Kusum. Dr. Frida. Yeah, you will be going first, sir. Dr. Venkateshwaran. Dr. Pradnya. Dr. Rakhi Datta. Dr. Surajit Giri. Yes. Amit Dikshit. Amit Khade.
Good afternoon, sir. I am going to speak on selective obturator nerve block for endoscopic resection of bladder tumor using peripheral nerve stimulator. In day-to-day practice, we often get patients of bladder tumor who are posted for resection, endoscopic resection. In some of these patients, you must have seen a sudden violent contraction of the thigh muscles called as adductor jerk or obturator jerk. This is specially seen if the tumor is large and is present on the inferolateral surface of the bladder wall. This adductor jerk occurs because the obturator nerve runs very close to the inferolateral surface of the bladder wall, and there is direct stimulation of the obturator nerve by the current used for resection. This is not only distracting to the surgeon but can cause potentially dangerous complications like bladder wall perforation, hemorrhage. At times the surgeon may end up with incomplete resection of the tumor. The yellow structure is the obturator nerve running across the pelvic rim, lying very close to the bladder wall. Various methods have been described to reduce the adductor jerk, like reducing the current, shifting the patient plate from buttocks to the thigh, performing the resection at low bladder volume so that the bladder wall falls away from the obturator nerve, or using laser for resection wherein the energy does not dissipate beyond 3 to 5 millimeters of the bladder wall. The standard textbook of urology advocate use of general anesthesia with muscle relaxants, but as these patients are old with their concomitant medical diseases like hypertension, diabetes and IHD, majority of the anesthesiologists would prefer rather spinal, but in spinal the jerk is not abolished as the nerve is directly stimulated. So it can be abolished if the nerve is blocked beyond the point of stimulation by the current. That block can be done by selective obturator nerve block using a peripheral nerve stimulator. In short, the anatomy, the obturator, the green one is the obturator nerve. It is basically more of a motor nerve, and it is derived from L234. In the abdomen, it descends, it lies within the psoas muscle initially, then comes out of the pelvis through the obturator foramina superior part lying above the obturator vessels. The right-sided picture shows the division of the obturator nerve after coming out from the obturator canal. It divides into two branches, anterior and posterior. The anterior branch supplies adductor longus, adductor brevis and gracilis, whereas the posterior branch supplies obturator externus and the adductor magnus. How the block is given: the patient is made supine after spinal anesthesia. The thigh is abducted at 30 degrees. The main landmark is pubic tubercle. The point of entry is 1.5 to 2 cm lateral and caudal to the pubic tubercle. In blind technique, 22 gauge spinal needle is used. It is inserted perpendicularly in till it hits the bone, and then it is redirected laterally and superiorly for 2 to 4 centimeters, and 15 ml injection of local anesthetic is made in fan-shaped manner. But the more certain approach is the nerve stimulator technique, wherein initially the current used is 1.5 milliamperes. 5 centimeter stimulus needle is inserted vertically in till you get the contractions of the adductor group of muscles. Then the current is reduced to 0.5 milliamperes, and after confirming that you are not in the vessel, you can inject the local anesthetic. 10 ml of sensor can 0.5% was used. The B. Brown nerve stimulator has brought up a revolution in the field of regional anesthesia. This is in short the anatomy. This is the pubic tubercle, and lateral and caudal to that is the obturator nerve, from where we are going to have the block. The thigh is abducted at 30 degrees. The blue dot is the pubic tubercle. The red line is the femoral artery. You have to go lateral and caudal to the pubic tubercle. This video will show the block. Again the blue dot is the pubic tubercle. You have to go lateral and caudal to it. Initially the current is kept at 1.5 milliamperes. You have to go straight inside, manipulate the needle till you get the good contractions of the adductor muscles. You are getting the contractions. Now you reduce the current to less than 0.5 milliamperes and see that contractions persist. At this point, if you are getting contractions, you can give the local anesthetic after confirming that it is not in the vessel. The complications are rare in this block, but books have described perforation of bladder, rectum or spermatic cord. Accidental puncture of obturator vessels is rare because the vessels lie posterior to the nerve. The contraindications are patient refusal, coagulopathy, ilioinguinal lymphadenopathy, perineal infection or hematoma, pre-existing obturator neuropathy in the form of groin pain. In conclusion, obturator nerve block combined with spinal anesthesia is an effective technique for preventing adductor jerk during endoscopic resection of bladder tumors, especially inferolateral wall tumors. This is especially important in elderly patients in whom general anesthesia can be avoided. Complete resection of the large tumors is possible without any complications. It is fairly safe and simple block. The take-home message is obturator nerve block is a must for all lateral wall bladder tumors done under spinal anesthesia. These are my references. Operation theatre kits, no more. Thank you.
Hi, thank you for your presentation. I have two questions. Number one, how your block is done after spinal anesthesia, and how do you assess whether your block works or not? And number two, in your study, how do you determine the outcome? I haven't heard anything about what happened to the patient in your series of cases.
After spinal anesthesia, if the surgeon is getting the adductor jerk, that means the nerve is stimulated. And after the block, once you give the injection, the contractions stop. And one more confirmatory test is you can increase the current to 2 milliamperes. And if you are not getting contractions at that point, that means your block is adequate. And after the block, you can see the result immediately. The spasms decrease after the block.
Did you look at the incidence of motor jerk in this study to demonstrate that your block is effective?
In some patients, you can have some reduced intensity of adductor jerk because the posterior branch may at times be missed. In those cases, you can get, and for that you have to use ultrasound so that you can block the two nerves separately.
Chan was trying to tell you
Pardon,
is,
sir, I can't hear.
what Professor Chan was trying to tell you is that you should have had a methodology to identify the success rate of your block.